All right, let's move into some more specialized areas. First, inflammation markers. How do we measure general inflammation in the body?
Yeah, when the body's sort of generally inflamed, what numbers jump out on a lab report?
The two most common are probably C-reactive protein, CRP, and the erythrocyte sedimentation rate, ESR. CRP is what's called an acute phase protein made by the liver. Its levels rise very quickly and dramatically, sometimes 100 to 1,000 times the normal level, which is usually less than 5 milligel, though different assays have different ranges, in response to inflammation, infection, or tissue injury. It's very sensitive and useful for tracking inflammatory activity, like in autoimmune diseases such as rheumatoid arthritis or lupus, or monitoring infections.
Okay, and ESR.
ESR, or Lised rate, measures how quickly red blood cells settle to the bottom of a standardized tube of blood over 1 hour. When inflammation is present, certain proteins, like fibrinogen, increase in the blood, causing red cells to clump together and fall faster. So a higher ESR indicates more inflammation. Normal ranges vary with age and sex, for example. For an adult male under 50, it might be less than 15 millimeters.
Now, this raises an important question. If both show inflammation, are they conclusive?
That's the key point. No, they aren't conclusive or specific on their own. They are non-specific indicators of inflammation. An elevated ESR or CRP tells you something inflammatory might be going on, but not what or where. Many conditions can raise them. Infections, autoimmune diseases, cancers, kidney disease, even anemia or pregnancy can affect the ESR. So they always need to be interpreted alongside the clinical picture and other more specific tests. We also have more specific markers like rheumatoid factor, which is an autoantibody often found in rheumatoid arthritis. High levels can suggest more aggressive disease.
Okay, then there's arterial blood gas analysis, or ABGs. This sounds really technical, but it's about understanding the body's vital balance, right?
Right.
Oxygen, carbon dioxide, pH.
Exactly. ABGs give us a critical real-time snapshot of a patient's respiratory status and acid-base balance. It's usually drawn from an artery, as we discussed. The key components measured are PaO2, the partial pressure of oxygen dissolved in arterial blood, shows how well oxygen is moving from lungs to blood. PaO2, the partial pressure of carbon dioxide, shows how well the lungs are removing CO2. pH, the measure of acidity or alkalinity, normal, is tightly controlled between 7.35 and 7.45. Bicarbonate, HCO3, a key buffer that helps maintain pH. And oxygen saturation, SaO2, the percentage of hemoglobin carrying oxygen.
How do we interpret these, especially the pH changes you mentioned in mnemonic?
Yes, the Rome mnemonic is helpful. Respiratory opposite, metabolic equal. It relates the pH change to either the PaO2, respiratory component, or the HCO3, metabolic component. So if the pH is low, acidosis, and the PaO2 is high, they move in opposite directions relative to normal. It suggests a respiratory acidosis. Lungs aren't blowing off enough CO2. If the pH is low, acidosis, and the HCO3 is also low, they move in the same or equal direction. It suggests a metabolic acidosis, too much acid produced or too much bicarb lost. The same logic applies to alkalosis, high pH, respiratory alkalosis, high pH, low pH2, opposite. Metabolic alkalosis, high pH, high HCO3 equal.
And the body tries to fix imbalances.
It does through compensation. If the primary problem is respiratory, the kidneys will try to compensate by adjusting bicarbonate levels, metabolic compensation. If the primary problem is metabolic, the lungs will try to compensate by adjusting breathing rate to change PaCO2 levels, respiratory compensation. Analyzing these compensation patterns gives even more info. We also often calculate the anion gap. It's basically the difference between the main measured positive ions, indications primarily sodium, and negative ions, anions primarily chloride and bicarbonate. A high anion gap, say 12, 14 mMTUL, depending on the lab range, sometimes even 20 is used as a clear cutoff, usually points towards specific types of metabolic acidosis, where unmeasured anions like ketones in diabetic ketoacidosis or lactate have accumulated.
Right, moving beyond blood and ABGs, analyzing other body fluids provides incredibly valuable, specialized information.
Yes, like urine analysis. We know the basics, but what can a really detailed look at urine tell us unexpected things? Oh, definitely. A full urinalysis is incredibly informative. It starts with a gross visual examination. Color. Normal is typically light yellow due to urochrome pigment, but it can change dramatically. Red might mean blood, hemoglobinuria. Dark brown could suggest liver problems. Certain drugs or foods can turn it orange or even blue-green sometimes. Appearance should be clear. Turbid or cloudy urine often suggests infection, pus, bacteria, or crystals. Odor. Normal is faintly nutty or aromatic. A fruity smell can indicate ketones, diabetes. A foul, fetid odor strongly suggests infection. Rare metabolic diseases even have characteristic smells, like maple syrup urine disease.
Wow, and the chemistry.
The chemistry dipstick gives quick reads on several things. pH can indicate acidosis alkalosis or risk for certain kidney stones. Specific gravity measures urine concentration reflecting hydration status. Glucose should be negative. Presence suggests high blood sugar spilling over. Ketones indicate fat metabolism, seen in starvation, uncontrolled diabetes. Protein, normally very little. Significant protein, proteinuria suggests kidney disease, often from diabetes or high blood pressure. Nitrites and leukocyte esterase are indicators of urinary tract infections, UTIs.
And under the microscope.
The microscopic examination is crucial. We look for white blood cells, WBCs, or red blood cells, RBCs, indicating infection or bleeding. We look for bacteria. And importantly, we look for casts. Casts are cylindrical molds of protein and sometimes cells formed inside the kidney tubules. Their presence indicates something is happening within the kidney itself. The type of cast gives clues. Red cell casts strongly suggest glomerulonephritis. White cell casts suggest kidney infection, pyelonephritis. Muddy brown granular casts are characteristic of acute tubular necrosis, ATN. We also look for crystals. Some are normal, but others can indicate kidney stones or certain metabolic problems, like calcium oxalate crystals after ethylene glycol antifreeze ingestion.
Okay, urine is complex. What about other fluids like stool or CSF?
Stool analysis can involve various tests. A common one is the fecal occult blood test, FOBT, which screens for hidden blood, indicating bleeding somewhere in the GI tract. Microscopic examination can look for pus cells, suggesting bacterial infection like dysentery or parasites. Chemical tests might check pH or look for excess fat, steatorrhea, indicating malabsorption problems. Cerebrospinal fluid, CSF analysis, obtained via lumbar puncture, spinal tap, is critical for diagnosing conditions affecting the brain and spinal cord. Gross appearance. Normal CSF is crystal clear and colorless. Turbidity suggests infection, meningitis. Yellowish discoloration, xanthochromia, can indicate previous bleeding in the brain. Biochemistry. CSF glucose is normally about 60% of blood glucose. It's typically decreased in bacterial meningitis as bacteria consume it. Protein is normally low. It increases in meningitis and other inflammatory conditions. Lactate levels can rise in hemorrhage or trauma. Microscopic. Cell counts are key. Normally, very few cells. Increased lymphocytes might suggest viral meningitis or multiple sclerosis. Increased neutrophils point towards acute bacterial meningitis. Specific stains and cultures identify infectious organisms. And briefly, synovial fluid analysis looks at the fluid from within joints. Its appearance, clear, viscous normally. Cell count, WBC, is increased dramatically in septic arthritis. Glucose protein levels and crystal analysis for gout or pseudogout help diagnose joint diseases.
Okay, almost there. Lastly, let's touch on how tests are often grouped into panels for efficiency and the idea of therapeutic drug monitoring.
Right, labs often group commonly ordered tests into panels. This is efficient for the lab and often provides a good baseline assessment. The basic metabolic panel, BMP, sometimes called Chem7, typically includes electrolytes, sodium, potassium, chloride, bicarbonate, BUN, creatinine, and glucose. It's a quick check of kidney function, electrolytes, and sugar, often used in emergency rooms or for basic monitoring. The Comprehensive Metabolic Panel, CMP, includes everything in the BMP plus liver function tests, ALT, AST, ALP, bilirubin, and proteins, albumin, total protein. Gives a broader metabolic picture. You might also see panels like a routine blood test panel for annual checkups, or a pre-surgical panel to ensure a patient is fit for surgery.
And drug monitoring.
Therapeutic drug monitoring, TDM, is measuring the concentration of a specific medication in a patient's blood. This is crucial for drugs that have a narrow therapeutic window, meaning the range between an effective dose and a toxic dose is small. Examples include certain antibiotics, like aminoglycosides, for example, amikacin, anti-seizure drugs like phenytoin, heart medications like digoxin, and immunosuppressants. TDM helps doctors ensure the patient is getting enough drug to be effective, but not so much that it causes dangerous side effects or toxicity. It allows for personalized dose adjustments. So we've covered a huge amount today. But the core message, the really crucial takeaway, is that while these lab values are incredibly powerful, they are ultimately just one piece of the puzzle. They provide objective data, yes, but they always need to be interpreted within the context of the individual patient, their symptoms, their medical history, the findings from a physical exam. They are an adjunct to clinical judgment, not a replacement for it.
Exactly. And it's often not about a single number being slightly off on one particular day. It's about the trending, right? Watching how values change over time in serial tests. That pattern tells a much richer story about whether a condition is improving, worsening, or staying stable.
Absolutely. If we just step back and think about it, it's quite amazing. A tiny vial of blood, a small cup of urine, can reveal such an incredible depth of information about the complex, hidden workings of our bodies. It truly highlights the intricate dance of countless biological processes all working, usually seamlessly, to keep us healthy. It's a window into that unseen internal world.
So here's a thought to leave you with. As our scientific understanding keeps growing, as testing technology gets even more sophisticated, how might our whole concept of normal lab values change? Could they become even more personalized? And what completely new insights might these tiny numbers unlock about our individual health journeys in the years to come? We really hope this deep dive encourages you to stay curious, to ask questions, and to listen to the often silent but always important stories your body is telling through these values.